On behalf of Intas, I would like to welcome all the delegates registered for this webinar to this session, interesting session on individualized ovarian stimulation protocol. We have some excellent speakers today, and I think Dr. Kundan Ingle, the chairperson of Infertility Committee, FOGSI, would introduce you to all the speakers and start the proceedings. Dr. Kundan Ingle, you can please start the remaining
Thank you,
proceedings.
Mr. Durga. So good afternoon to all my friends, colleagues, teachers, and Foxians. I welcome all of you to Fertility Expert Meet organized by FOGSI Infertility Committee. This is an initiative by FOGSI under the leadership of Dr. Alpesh Gandhi, President FOGSI, and Dr. Ramni Devi, Vice President FOGSI. It is our attempt to connect you to the experts from all over the world. This is our first meet through this webinar in 2020. As said by loyal Jack Lehman, never stop learning as life never stops teaching. So ovarian stimulation is a conglomerate conundrum till today, and each patient is responding differently to the ovulation stimulation protocols. It is like a closed book which reveals its riddles every time you open it. The more you discuss, the more aspects are revealed. Many factors affects its aftermath. So Fertility Expert Meet will bring you the facets of this complex science. This meet will form an avenue between experience and learning, which will help us to achieve successful holding, resulting into favorable outcome. We have every extreme academician today from Barcelona, Spain, Professor Dr. Nicolas Polizos, who is not only stalwart in the field of assisted reproduction, but also the research contributor to optimize ART success. Today, he will brief us on individualized ovarian stimulation protocols. May I request our viewers to write questions to our experts in the chat box, which will be discussed after his presentation in question and answer session. Dr. Apurva Palam, National Coordinator from Infertility Committee, will coordinate this session. Now I request Dr. Alpesh Gandhi and Dr. Ramni Devi to chair this session. And I request Dr. Alpesh Gandhi, President FOGSI, to give his presidential speech.
Dear friends, very good afternoon to all of you. At the outset, on behalf of FOGSI, I extend warm welcome to Dr. Nicholas, our faculties, and all the viewers. I would not take much time. WHO has estimated the overall prevalence of primary infertility in India is somewhere between 3.9 to 16.8%. It varies in different states of India because we know that each state is like one country. We have different prevalence in different states. And we all know that the ovarian stimulation is the essential or the important part of the management of an infertile couple. There are different protocols and different patients require different protocols. Sometimes we become confused which will be the better for this patient. The theme of FOGSI for this year is safety first. And for the safety of a patient with infertility, it is also very, very important to know which protocol is more suitable for which type of patient. So today we have Dr. Nicholas with us, who will guide us for the which protocol is better and more suitable for which type of patients. We require individualized treatment. I must congratulate Kundan Ingle, Chairperson of Infertility Committee, and his committee for bringing out such very useful topic webinar. Infertility Committee, FOGSI, is doing excellent work. In this difficult time also, they are trying to reach to you with good academics, which can be helpful in our routine practice. And when we have the routine practice after this post-COVID time also, it will be very much useful in our practice. So with this brief welcoming address, I wish all of you a great day, happy learning. And with this, I hand over mic to my co-chairperson, Dr. Ramni Devi, Vice President FOGSI.
May I request Dr. Ramni Devi, Madam, to introduce our today's speaker, Professor Dr. Nicholas Polidas.
My thing is muted.
Yeah, we can hear you now.
Okay, I'll share my screen. First of all, I congratulate Dr. Kundan Ingle, who has been doing a very good work conducting so many international webinars on infertility committee. And I also thank Dr. Alpesh Gandhi for permitting our committee under me to do such excellent work. Now today, we have with us Professor Dr. Nicholas Polisas, who is a clinical and scientific director of the Department of OBGYN and Reproductive Medicine from Texas University Hospital, Barcelona, Spain. When I went through his CV, it is something amazing. Okay, so he is the professor of reproductive endocrinology in the Department of Clinical Medicine in the University of Aarhus in Denmark, medical director, Center for Reproductive Medicine in Brussels until 2017, and as a professor in Brussels until 2019. He is a principal investigator in several large pioneering multinational trials. He is a key opinion leader in the field of reproductive medicine for the treatment of poor ovarian reserve in IVF programs, prediction of ovarian response and premature ovarian aging. He has delivered more than 150 invited lectures in the international congresses. He is a section editor in RBMO, member of ESHRE Guideline Development Group for Ovarian Stimulation, editorial consultant for the group PIER of ACP. He has more than 140 publications in peer-reviewed journals and indexed with PubMed with greater than 3,600 citations. It is something amazing. He has an index of 36 in ISI Web of Science, and field of interest includes reproductive endocrinology, OR markers, poor ovarian reserve to stimulation, and genetics of premature aging. So with this, I welcome Dr. Nicholas, who has been a pioneer in the field of ovarian stimulation protocols, especially for poor ovarian reserve, which I think is a very, very important one that all ART consultants should know. Because the success of ART is going to depend mainly upon the ovarian stimulation protocol, which has to be individualized. I welcome Prof. Nicholas Polisas.
Thank you so much, Dr. Deve. Thank you for the nice introduction. You forgot one thing, that except from all this, I love India too much and I'm visiting India very frequently. So I think I have Indian genes inside me. Okay. So I would like to thank you all for the kind invitation. It's an honor to give a lecture for FOGSI, and I would like to thank also my good friend Kundan for the invitation. We will try to talk about individual ovarian stimulation protocols and how we treat patients today and what is our perception for stimulation in the future. Because all these years we have changed a lot and we have developed many new strategies on treating our patients. But I will try to go a little from the scratch, explaining what we do, what we should do, and what we might do in the future. These are my conflict of interest. And I will start about stimulation in general. We are living in the era of evolution. What we have seen all these years is that everything started at this single point, first IVF baby born. But this was only the beginning. It was the beginning of what we did, and we're here talking about ovarian stimulation because we have seen this first miracle happening. But after this, we have passed through different steps. We improved the way that we are treating our patients. We started using stimulation. beginning with clomiphene, then with gonadotropins. And then we realized that during this stimulation process, we need to control the late surge because we have a premature ovulation. We use the GnRH agonist protocol, but then we went a little further, realizing that we care about safety as well, using the GnRH antagonist protocol. And finally, going to new strategies like the freeze-all strategy. So all this journey is beautiful, it's amazing, we live it every day from the clinical part, but sometimes we forget that all these changes that we're implementing in the clinic, they go with a different technology. We're advancing not only clinically and in terms of medical products that we use, we advance in technology. What the super baby is holding is not a jar of marmalade. It's the first incubator. So for us, the younger ones that we don't know or we haven't lived this era, this is where everything started. And this was only the beginning, because after this jar, we managed to go to amazing technology, incubators, that we have cameras, that we follow our embryos. We freeze all in a different way, and we went to the freeze-all strategy. So all this has been a great change over the years that changed apparently our perception for the patients and also the way that we stimulate. So what we are called to discuss today and ask questions and have a discussion about is how should we stimulate our patients today in terms of way of injecting, and when we take into account that not all patients are the same, because we have different ovarian response categories. We have poor ovarian responders, normal ovarian responders, and high ovarian responders. So, ladies and gentlemen, what should we do today in terms of protocol, agonist or antagonist, in terms of starting dose, how intense we should stimulate, and finally, in terms of type of gonadotropin, how should we stimulate? These are questions that every young person that enters in the field will ask us and will try to figure out, and sometimes it is rather difficult to answer. So I will start from you, from the good part, normal responders, the big part of our population that hopefully we know that lately in our reproductive medicine services, there are coming women with lower ovarian response, but we still have many normal responders. And the question that we need to ask is, what should I use, agonist or antagonist? And the question has been dealt during the guideline formation group of ovarian stimulation in ESHRE, and we had controversies, but I think in terms of GnRH analog, the controversy doesn't exist. Why? Because we have evidence telling us that either way we use one or the other protocol, we will have similar live birth rates and higher cumulative live birth rates, slightly higher but not significant. But more importantly, when we use an antagonist protocol, we're talking about safety. We reduce by 50% OHSS rates. So in the modern ovarian stimulation, when a patient comes with a normal ovarian reserve, practically speaking, the role of GnRH agonist is minimal to zero. Why? Because I don't want many injections, because I don't want high risk of OHSS, and because third, I maintain very good pregnancy rates with my antagonist protocol. The second question that comes to the area of interest is, what about the dose? Should I use high dose, low dose? How much is enough? 100, 150, 225, 300? And then, of course, we have to take into account that we treat different women. Different BMI requires different dose. Different age requires different dose, and different ovarian reserve requires different dose. So all this decision-making process needs to be based on patients' characteristics and not only in one-size-fits-all concept. This does not exist in IVF. This does not exist in modern ovarian stimulation, and it's something that is for the past. But starting dose, we are tending to change our strategies, going to higher stimulation strategies, going to find more eggs. And this has been a matter of debate also during the guideline of FOGSI. Why? Because some people believe that a milder approach is better, and others believe that a more intensive approach is better. In a big study that we published in Fertility and Sterility in 2019, what we found was that actually when we treated when we included 15,000 women undergoing their first ovarian stimulation cycle in 14 different centers in Spain and Belgium, we really found out that the higher the number of oocytes, which is displayed in this axis, the higher the percentage of cumulative live birth rates, which is the dark blue bars. These tell me that if I get more eggs, I certainly increase my chance to have at least one live-born baby, with, of course, the risk, as you see here by the gray line, increasing the chance of freeze-all embryos. So, yes, ovarian stimulation, modern ovarian stimulation in normal responders is not a mild approach, is a normal to high approach. But again, we have to realize, as I told you, that not all women are the same. We have women that they have advanced states. Unfortunately, modern way of life, at least in the Western type that we live, and I'm sure in the big cities of India, what is the face of patients that we see? A big banker from the Bank of India coming to you at the age of 43, feeling so young to have a baby. Of course, we have to realize that in these women, we need eggs, and we need a lot of eggs. In a study that we published in Human Reproduction in 2008, we have shown that the higher the number of oocytes, the stronger that we stimulate these women, the higher the chance to have at least one live-born baby. Why is this? Because age is associated with aneuploidy, with abnormal embryos. So if I have women at their 40s and I'm trying to stimulate, going from 3 to 5 eggs is completely unrealistic, especially if I have the opportunity to get more. Of course, this is not the same when we're talking about women of younger age. And this is something that we need to communicate in a decent way to our patients. And why is this? Because if we see this graph, which shows the euploidy rate, the normal embryo rates, which are the blue bars of embryos according to age, you will see that when we have women up to the age of 34, 35, the chances of having one normal embryo, they're sky high. If I have 10 embryos, 7 or 8 would be normal. We have 70 to 80% euploidy rate in these women that they're young. And also, what other studies have shown to us is that the blastulation rate, the percentage of oocytes that they reach the blastocyst stage, irrespective of the number of oocytes retrieved, you see here you have low oocytes and high oocytes, is always the same at the level of 50%. These patients, if they have 4 oocytes, it's highly likely, if they have an age less than 38 years old, that 2 of them would be blastocyst. And then the aneuploidy rate is very low. So what I'm trying to tell you is that yes, we need eggs, but not always, because not all women are the same. The last question that it comes to the agenda is what we're doing in terms of gonadotropins. And this has been an issue that has been discussed by the ESTRA guideline group, and we came up to the discussion and the conclusion that either way, if you use a urinary or recombinant, the chance is going to be the same. Why? Because first of all, you don't have any difference in terms of live births or ongoing pregnancy rates. You don't have any difference in terms of cumulative live birth rates, and you don't have any differences in the risk of OHSS. So, moving away from the normal ovarian responder patient, which appears to be the easy case, we go to more difficult and more complicated cases. Like the extremes. What extreme? Low ovarian response. Poor responders, which unfortunately we know when there have been studies coming from India that more patients have a low ovarian reserve, maybe it's something genetically associated but this is something that studies have shown that women from Asia or women from India, they come with a lower ovarian reserve compared to women of Western Europe. And this is a problem that might affect more profoundly in India. So how do we need to start treat this patient in terms of analogs? The studies have shown no difference. Ongoing pregnancy rates, either if you use antagonist versus long agonist or antagonist versus short agonist, are exactly the same through a meta-analysis published in 2013. In the more recent meta-analysis by Lampak in Human Reproduction Update, again, the live birth rates between agonist and antagonist in poor ovarian responders resulted in the same live birth rates. Frankly speaking, I would use personally the less invasive approach, which is the antagonist protocol. Why? Because I don't suppress so much my ovarian reserve. The only patient I would consider a GnRH agonist would be in case of lack of synchronization. If I have a stimulation with an antagonist and I see different sizes of follicles, a complete asynchrony in a patient with an androgen follicle count of 7, and I get 1 or 2 eggs, yes, this is the patient that I would consider using an antagonist protocol. However, the major problem that we see with the poor responders is that we are lost in translation. How are we lost? Because the definition that we have developed and we use for these poor responders is completely diverse. We don't know if we see these women who are the poor ovarian responders, despite having 30 or more years of research in this field. And what was the problem? In a systematic review that we published 10 years ago, we identified a major problem. What is the major problem? The major problem is that actually we don't know who are these patients are. Because if you see in this systematic review, we have found that among 47 randomized trials, 41 different definitions have been used. It's a huge number. It's a huge diversity. And it's even I would say more difficult to realize that no more than 3 trials use the same definition. And even the same groups use different definitions. So ESRE came, made a new definition, the Bologna criteria, taking into account different variables, but again, we are continuing to be lost in translation. Why? Because the definition is not enough when it includes an heterogeneous group of women. A definition is not enough when it doesn't identify response and ovarian reserve and group all women the same. And of course, clinically speaking, it's not correct if we don't take into account the age-related effect on oocyte quality. So, having said this, we identify a Bologna poor responder, a patient that might have 2 different phases. Woman of 25 years old, severe endometriosis, had the surgery, took out half of her ovary or the whole of her ovary, and her AMH crashes. She has 2 stimulations and a very low ovarian response. Is this patient the same with a banker of the Bank of India that comes to you after the age of 42, believing that she will get pregnant with a low AMH, not taking into account the age-related decline in the quality of the eggs? Apparently, they are not the same. Apparently, they are completely different, and their chances are completely different. So, Poseidon group came and made a new definition, taking into account age, older and younger women, but more importantly, ovarian reserve, and separated women to good ovarian reserve and poor ovarian reserve. So, question important. Are they the same, all these Poseidon group women? And the answer is simple and clear. Different groups, different prognosis. The study published in Frontiers of Endocrinology in 2019 has clearly shown that actually the 4 different groups are completely different in chances of cumulative live birth rates. having the best always in the younger women and the women that they have a higher number of oocytes retrieved. So how should we manage this patient? A poor responder comes to your clinic and asks you, doctor, I have been in 5 clinics, in Delhi, in Daipur, in Kolkata. What I have to do? You are my last savior and you have to give me the best advice. I have a poor ovarian reserve. If I go mild in these patients, if I go with lower doses, if I have an under follicle count of 1 or 2, are you gonna damage me? Am I gonna get lower chances of pregnancy? And the answer is actually that mild in specific, very, very poor prognosis cases can really be enough. We have seen studies published saying that the chances of pregnancy per cycle might be the same or even better with mild stimulation when the prognosis is really poor. And we have presented last year in ESTRA meta-analysis showing that live birth rates between mild and conventional stimulation are the same when the prognosis is really poor, and relative risk is actually 1. And we have seen that if you have a very low ovarian reserve, we're talking about patients that they have 1 or 2 or 3 follicles, when you stimulate them, you will not observe a great difference in the number of oocytes. Mean difference of less than one oocyte, 0.64, practically means nothing. So, frankly speaking, these women with a bad ovarian reserve might have the same good results if I go with a milder form or I combine with oral treatment. But what is happening when I have patients with an intermediate or good ovarian reserve? Poor responders that they come to you, you do your ultrasound and you find 5, 6, 7 oocytes. Is this extra egg worth it? Because if we see the literature, we will see that 1 egg or 2 eggs or 3 eggs can really make the difference, especially when we're talking about young women. And especially we're talking that a woman at the age of 18, 19, 30 years old would probably want a second baby or a third baby in the future. So our responsibility is to give them the same chance of success and not compromise their chances if we have the possibility to get more eggs. What is, however, more important is to realize that even the worst prognosis women are not the same. Individualized cycle start is something that I'm applying in all my patients. And I will tell you why. And what does it mean, individualized approach? A patient comes to you and she has an under follicle count of 1 or 2 with an AMH of 0.5. This patient that has this cycle of 1 or 2 under follicle count, in the next cycle or during the same cycle might have a completely different ovarian reserve. Why is this? Follicular waves. The theory of Bergold is that not only one wave occurs during a cycle, and you might have different waves. And we have evidence about intracycle variability. The cycle by Luke Romberts in Fertility and Sterility, women were treated with 3 consecutive identical cycles. And what has been seen is that we have seen that women from normal went to low and high response at a percentage of 12, 15, or 16%. So 2 out of 10 of your patients might have from normal go to low response, or vice versa, from low to high response, it can be a 40 or 50%. So a patient that you get in one cycle 2 or 3 oocytes, in another cycle, identical cycle might have more oocytes. Why is this? Because we don't know correctly the pathophysiology behind ovarian folliculogenesis and recruitment of follicles. What we see in our ovaries are the small antral follicles, and we don't know the whole mechanism behind which these follicles are reaching the stage. There are a lot of paracrine and endocrine mechanisms. The PTEN pathways plays a role, androgens might play a role, and each cycle might have different number of follicles. So what I suggest always when I have a poor responder is that Sometimes you might not need to give up, and we might need to wait for 1 month to catch the beautiful wave. Stimulation is like surfing. When you have the good wave, you will do an amazing surf. But when you don't catch the good wave, you will make a really bad slide. So you have to be sure to catch this wave. And for me, individualized cycle start might be something that we don't usually do, but we should actually do. Going to the other part, we're going to the high ovarian responder, women with PCOS, that I know again that you have a lot of PCOS women in India. And the question is, how should we stimulate these women? Should we be prudent? Should we be aggressive? Or should we use very, very low doses so as not to harm them? Of course, we don't need to hyperstimulate them. This is something that we don't want. So what I'm always telling to you is that let's see the evidence. And the evidence comes from this study, which randomized 2 patients in 2 different stimulation strategies. A conventional, which is 150 units, and a milder, which is 100 units. So what we have seen is that when you compare 100 to 150 units, you see that although there is no difference in terms of live birth rates between the 2 groups, what you see is that there is a difference in cancellation cycles. Women at the low group had 20% cancellations. What does it mean? 1 out of 5 women with a high ovarian reserve, with an androgen follicle count of 25, they ended up having a cycle cancelled. Can we allow this in modern IVF? Is it proper? And is it proper when we have the amazing option of the agonist trigger that we trigger and freeze all? Of course, someone might say, yes, but we have to be careful always because we don't need cowboys in IVF. A study published in 2013 has shown that even after agonist trigger, when you transfer, you can have a high risk of OHSS if you transfer in women with 65, 49, 33 OHIs. But this is something that we need to realize, that we have to be responsible. We don't want cowboys. The IVF cowboy image that we had, maybe it's for the far west. It's not for India. It's not for Europe. It's not for people that they think logically. Let's get rid of this IVF cowboy and try to realize that we have to be more careful. Of course, we have a big weapon in our arsenal of strategies, a freedom, which is called freeze all. And the freedom of freeze all has been developed by our group with Paul de Vries, the first paper published in 2011, introducing the OHSS-free clinic term and seeing that in 2016, when you randomize patients to a segmented cycle or to a fresh embryo transfer, when they're high responders, what you end up getting is higher live birth rates with the freeze-all strategy. So this can be the future. But we cannot forget the ugly face of intense stimulation, because in the end, there is an ugly face. And what is this ugly face making of? Number one, endometrial receptivity. The beautiful endometrium that we want to implant our embryos is not an organ that wants super high levels of estrogens. Our intense stimulation is probably going to disrupt the communication between the embryo and the endometrium. And we don't want this. Secondly, I don't want this to see these ovaries, even if my patient will not have OHSS, because it's uncomfortable. And I don't need all these eggs. And I don't want to end up having an ovarian torsion, because even if I control it as much as possible, I might end up having this. And some of you might say, I don't want progesterone elevation because it's bad for my patients, and this is something that we have to discuss. So, should we freeze for all the patients? We freeze for high ovarian response, for sure. But should we freeze for progesterone levels? Because if someone sees the literature that has been published, the story is very clear. The story is very clear. When we see progesterone levels above 1.5, Ernesto Bosch told us in 2010 that the pregnancy rate crashes. You see here from 36% to 20 or 11%. And this came also by future grand meta-analysis with 60,000 patients telling us that above 1.2, 1.5, 1.9, the pregnancy rates are bad. So should we really freeze when progesterone is high, or it depends on what we measure? And I want to tackle with this issue because it's a part of individualized stimulation. If we take a decision to use a strategy of freezing all our patients when we have a high ovarian response and a high progesterone levels, we have to make sure that the strategy is the best, or the cutoff that we use is the correct. Is it the correct, or apparently the progesterone levels are something that it's not stable during the cycle or during the day of triggering? And I will show you a study that we finalized and we published last year in Human Reproduction, in which we measured progesterone during the day of final oocyte maturation, the day of the triggering, to see how much stable is the progesterone during the day. And we found out a really crazy decline in the progesterone levels during the day. Although we trust one single measurement, we have seen that progesterone declines during the day by 44%. A patient that comes in the morning will have completely different value if she comes in the evening. And if we measure it with different assays, we have seen that a different kit that we are using, we have changed our kits in our clinic, and we have seen that among all the visits, the progesterone is 41% with the new kits compared to the older kits, saying to me that the stability of progesterone is not clear. And be very careful when you decide to freeze with a progesterone value of 1.5, because apparently this might not be correct. Of course, what someone of you would say, so what is the problem? Is that a big problem? Freeze all, you told us, Dr. Polizos, that it's freedom, it's freeze all. So if it's really freedom, why should we not freeze for everyone? Isn't it better? In the end, where is it better for a golden embryo that we create after a proper stimulation to be put? In an ugly uterus that we stimulate, or in an angry freeze? And this is really something that makes sense and makes questions to us. I don't know what to do. Am I harming the embryo? Or are all the embryos the same? Are all the patients the same? This is a great question, because we know very well from the literature that it has been published that when you treat a normal responder patient, freeze all or freeze is equally effective. Large studies published in New England Journal of Medicine showing exactly the same pregnancy rates, and even studies coming later in Lancet like this, 2019, says that frozen embryo transfer group might even perform better. So in normal responders, I see that probably there is no difference. I definitely need to use it in my high responder. In the normal responder, seems that there is no difference, and we have a new study coming in BMJ next month, published about frizol. But what about this patient, which is the patient that probably would suffer more from the progesterone rise, the poor ovarian responder? What does the literature say, and where are we in terms of stimulation for this patient, and what is the effect of a frozen embryo transfer cycle compared to a fresh embryo transfer cycle? The literature is not clear. If you see these studies, which are all retrospective, they told us that ongoing pregnancy rates appear to be more or less the same, or at least not better, with a low quality of evidence. But I want to raise a great concern. Why? Because of this study by Archaya, utilizing the data from the SART from the United States, which told us that when you compare freeze, which is the blue bars, compared to freeze, freeze is better when I have a high oocyte yield. In the high responder, freeze is always better. Safety and efficacy. In the normal responder, 6 to 14 oocytes, it seems to be more or less the same in live births and clinical pregnancy rates, small differences clinically insignificant. But look at this. When I have patients that they have less than 5 oocytes, the pregnancy rates appear to be better in the fresh cycle. Question important. I have a woman of 39 that suffers embryo quality, that has few eggs. What is better, ladies and gentlemen? To put it in the fridge or to put it in the uterus? And if you can be sure, you have to tell me because I would follow your advice. Why am I telling you? Because I'm not sure. And also, I'm not sure that if we start freezing even the stones, what are we do for the future? What are we going to do? Why? Look at this, NBC News. Nation's fertility clinics struggle with a growing number of abandoned embryos. We abandon embryos, ladies and gentlemen. Women do not want millions of embryos. And this article in CBC News tells us that 1/3 of the cryopreserved embryos have been discarded or abandoned. If you have 1 or 2 cryopreserved embryos, you have a 30% chance to live them. If you have more than 10, you have even more chances. So we are stuck with these embryos in our fridges. And if you continue, especially in India, you're facing a population which is completely different from Europe. And at a specific point, your clinics are going to be managing many patients. When the financial situation would be better, definitely all will have access. So there is a bright future there. But with all these embryos, what are you going to do with them? Do you want them in your tanks? Because in the end, what we have the problem in Europe is that we cannot destroy them. And in the end, I want to really close this session and leave it open to discussion with a little a question that can raise concerns to all of us. Is really the maximum stimulation freeze-all the future for all? Because I will tell you that, yes, I love ice. When it's hot, I like to drink my beautiful juice with a lot of ice. And it's lovely. It makes me feel better. I love also skating. It's super nice. But we have to realize that sometimes we have to be aware of ice. Why is this? Why do we need to be aware of ice? Because simply, there is danger that we can walk over thin ice. And we need to realize that ice is not made for all. If we have the right vehicle to go over ice, we will definitely enjoy it. It's going to be fantastic. It's going to be beautiful. But if you have the wrong one, you might come up with beautiful or unpleasant, I would say, surprises. And we have to be careful to whom we apply our ice strategies and to whom we try to go to freeze-all, because in the end, freeze-all is not for all. Thank you so much for your attention.
So thank you very much, Professor Nicholas, for excellent overview about individualized ovarian stimulation protocol. I think many of our doubts are solved because of the evidence what you have presented to us. I will proceed to the next question because this is going to be interesting because there are lots of questions from our viewers. So I invite Dr. Apurva Palam Reddy. She is our National Coordinator for Infertility Committee. She's again a very good person and a very close friend. It's very pleasant to work with you all across India for Infertility Committee. Apurva is going to coordinate this question and answer session with Professor Nicholas. So Apurva, over to you. Unmute the voice, Apurva.
It's always nice when someone introduces you as a good friend more than anything else. That was a brilliant lecture, Professor Nicholas. So we're going to do rapid fire. So we have almost 50 questions that people have asked you, but I know we won't be able to take. I know you have backed up a lot of literature, so we don't want elaborate explanations. So we would probably just take single note answers so that we can take as much information as possible. Are we ready for this?
Absolutely. Let's go for it.
So we have Dr. Priya Selvaraj asking, is there any role of GCSF or growth hormone in poor ovarian reserve patients in your stimulation protocol?
Frankly speaking, no.
No.
Wow. There is a lot of evidence.
30 seconds.
You just use a lot of money to stimulate with growth hormone. There is no evidence from the early studies that this has made any effect. And the only study, which is the light study presented in ESFRE 3 years ago by Robert Norman from Australia, didn't find any difference. The problem is that you have these follicles that exist in your ovaries. You stimulate your FSH.
Anything else that you would kind of really recommend to improve the response in a poor ovarian reserve, apart from the regular stimulation protocol? Any medical management?
For me, I believe in androgens. I'm an androgen guy, but I want to finalize the study. So we're doing a big study with androgens, and we will see what is happening. I think we will have the interim analysis next year. So we will see if there is any effect there.
So androgens for about 21 days, you're talking about testosterone gel?
Testosterone gel, but it needs much more days. But it's off-label use. We're doing a big study which is called the transfer, and we will see the results soon about this. Probably next year we'll have something.
Okay. So continuing the same question from Dr. Priya, is there any optimum dose for an agonist or a HCG that you would do in a dual trigger? And of course, dual trigger, your comments in poor ovarian reserve.
I'm using dual trigger when I have a synchrony of the follicles. When I have follicles that they are small and big, and I see that I have bigger ones and I need to trigger, I'm using the dual trigger. Why? In a way to support the growth of the smaller ones and get them a better cohort of follicles. So I'm not against this. There is evidence in favor or against, but I'm not against this. The dose that I use is going to be depending on the risk of hyperstimulation. If there is a risk of hyperstimulation, be careful of HCG. High responder, no dual.
Mm-hmm.
Normal responder or low responder, yes. Full dose HCG and 0.2 milligrams of generates agonist of triptorelin.
0.2 milligrams of triptorelin per kg body weight.
If you give triptorelin is 0.2, yes.
Okay. All right. And how about your idea about using only HMGs for poor ovarian reserves?
We're using a lot of mixed protocols here, actually, in Spain. So we're using both.
And quickly adding to that, do you have any your stimulation protocols? Does it change based on the day 2 FSH, LH, and progesterone levels that you kind of do?
Can you repeat the question?
Based on your day 2, that is your basal FSH and LH levels, does your stimulation protocol of the type of drug that you are using, the HMG or LH or FSH, does it vary?
Okay, I will reverse the question. Does the FSH levels have any receptor for you? No. What I see is follicles. The follicles, the antral follicles have the FSH receptors. If I see follicles, I never measure my FSH. The FSH would be very high when I don't have follicles. If I have these small follicles there, you have your ovarian reserve. Bombard, stimulate, high doses, maximum doses, and start to stimulate your patients. If I have 3, 4, 5 follicles, that's what I do. I have a patient today, Ladana, that I treated here. She had always FSH. She told me she came with FSH 40. I see a cycle, I see 5 follicles, I stimulate her. She has 3 oocytes now extracted. She's 36 years old. I hope that I will get embryos.
So you're saying that if you are seeing a reasonable antral follicle count, you're not going to go ahead and do an FSH. And even if the FSH is high, you will still go ahead and continue doing your HMGs.
I don't do it. Sometimes we get too many information, we complicate our lives.
So, okay. All right.
You have follicles, they respond.
Okay. We had a question from Dr. Dilip who says, role of HCG in PCOS.
There is a new study coming, HCG in PCOS. The HCG LH activity or the HCG trigger? I don't understand what they want. If we're talking about the HCG trigger, no. PCOS, agonist and frisol, especially for the virus. HCG-driven LH activity through HMG, yes, there is a new study, the Megaset HR, which will be published soon. It has been presented 2 years ago for the HPHMG. It has been presented showing that you have lower miscarriage rates and showing that you have very good pregnancy rates. Yes. So what I'm hearing sometimes is that the problem with the HMG is the mixing. So when it will come with the pen, it's going to be much more easier. But the studies have better results. Of course, there are other studies that they show that they are having equal results. In the end, I think it should be very individualized. I'm not dogmatic, and this is something very important to realize. We should not be dogmatic in IVF. Each patient is different. We can start with each gonadotropin we want, and we can change afterwards depending on the response, but I don't believe I'm a single drug person, not at all.
But I think we still do not have that drugs for HCG use in ovarian stimulation yet. The market is still open for it.
No, we're talking about the HPHMG. So the HPHMG was a part of HCG is what the studies have been used. Going with low dose HCG in the end of the follicular phase has been also done in the past. The group of Philip Corey has done many studies that you can supplement few doses in the end of the follicular phase with HCG, but don't try this. You have to dilute, you have to go into this. It's going to be much more complicated for you of the patient, and it's high risk that they will make mistakes. So instead of avoiding mistakes, I believe it's better to go more with what you have in your arsenal of drugs, with the or with the HP.
So we have a question from Dr. Nalina saying, do you increase or titrate your gonadotropin dosage in an antagonist cycle?
This depends on my response. I prefer not to do this. I don't want to go with a step-up protocol. Because I'm not used to this, I never started, and sometimes you go with long stimulation. If I had to do something, I might do a step down. I prefer to go with a little more intensive stimulation. Let's say I have a patient with an AMH today. I saw it, and it's a friend of mine. I saw here AMH 307, under follicle count 17. I start with 200 units, 225, and I say to her, Natalia, don't worry, I will start with this. 5 days later, I see her. If I see an excessive response, I can adjust a little lower the dose, and I'm not gonna need to step up. If I step up, I start with a very low dose and I step up, my initial follicular recruitment already starts. I will increase my asynchrony of the follicles, and it's highly likely I will end with different cohorts of follicles, which will make a problem for my patients.
So essentially, I think we need to take the call regarding the dosage in the beginning of the stimulation protocol itself and stick to it. And okay. Question from Dr. Sada Singh. So how much progesterone is good enough for implantation and maintenance of pregnancy?
How much? Can you repeat it?
Progesterone levels on the day of embryo transfer. Are you routinely practicing testing progesterone levels on the day of embryo transfer, and do you increase or decrease your luteal phase support?
It depends on the type of embryo transfer. So if you have endogenous production, which means that we have a natural cycle, we have published a paper that has seen that 10 nanograms is enough. So above 10 nanograms, if you are below, you need to supplement. If we're talking about the stimulated cycle where you go with vaginal progesterone, it's enough. You don't need to measure. You have already corporal lutea that produce a little progesterone, and the progesterone you supplement is enough. Big problem is when it comes to an artificial frozen embryo cycle. Why? When I have an artificial frozen embryo cycle, I have zero endogenous progesterone. And we have published studies with euploid embryos by Gagiotti Sofia, which is my collaborator, and we're publishing a new one now, that if you have levels below 10, after vaginal supplementation, you will have sky-high miscarriage rates. What you need to do is measure your progesterone the day before embryo transfer. If your level is below 10, start using injectable. That's what we use to make it more individualized, not only stimulation, but also individualized luteal phase support.
If you're already in the use of, sorry, if you're already using injectable preparations, then is there any role of even testing it?
Not at all. If you're using intramuscular, you will have sky high, 67. What is the problem is that your patient will be crying from the pain when you inject every day your injectable. So more individualized if you want it, and you see the levels. And if you use intramuscular that exists in India, try to use it only every 3 days. There is a study in Fertility that with the vaginal and injectable every 3 days, it's sufficient.
So I think as a conclusion, if you're doing a natural cycle transfer, having about 10 nanograms is good enough. If you're doing frozen embryo transfer, HRT stimulated cycle, then probably you need to have higher levels. Yeah. I think we have a question.
It's again 10. The level, 10. I'm sorry, 10, but it's more frequent to happen in an artificial cycle. In a natural cycle, because you have your corpus luteum and produces the progesterone, is less frequent.
Sure. We have a lot of questions on how to stimulate PCOS, and that's very interesting. We have Dr. Rita, Dr. Purvi, Dr. Balachandran, Dr. Surya Narayan, and Dr. Amil. All of them have asked, how do we stimulate a resistant PCO? Someone who's already having a high AMH, high AFC, started them with 225, and then, you know, the response is bad. So how do we proceed? And quickly, is there any role of recombinant LH in these patients? And also, do you use only HMG for these patients?
No, as I told you, thank you so much for the nice question. So this is a profile, I don't use only HMG, I use all the gonadotropins. So this is for sure. Some patients, yes, they will benefit from HMG and I will use it. I had a patient that went very bad with recombinant FSH. I changed to HMG. So Lucia, I saw her yesterday, first cycle, 16 eggs, 0 embryos. Second cycle, I did 15 eggs and I got 5 embryos. Maybe it's luck. I have seen the opposite also. I'm telling you what I saw yesterday in my consultation. So it's not one medication for all. Try to be more, not be dogmatic, I'm telling you. Well, I don't like dogmas in IVF. In terms of resistant PCOS, we don't have so many frequent patients like what you have in India. So I have to be frank that my experience is limited. What I have seen some patients, and I had some patients mainly of Arabic origin that they had a higher BMI. The problem when we go into this is also the BMI, because many of them have high BMI. You start them with 25, they might be resistant, and then sometimes they start booming up and have 50x. In the end, in these patients that they are more resistant, yes, these are the patients that I will do the step-up protocol. The only patient population that I like to do the step up, it's this. So I try to step up the dose until I find the dose where they will seem that the ovary starts starting. I don't start my antagonist early. A major mistake that we do in these patients is do a fixed protocol. Forget it. Buy fixed for the strong PCOS. If you block your follicles by starting your antagonist early, your cycle is going to be long. So don't start, do a step up. And this is what I have seen in these difficult cases. And then you might end up stimulation with 300. What you do? Freedom. Freeze all, freeze all.
Interestingly, that's the next question by Dr. Sonia. So in case if you're doing an anti protocol, are you going to follow a fixed protocol or are you going to follow a flexible? And if you're following a flexible, are you going to go it based on just the follicular size, or are you going to get estrogen levels repeated? Because, you know, we know that sometimes the estrogen levels are going to be really high, or rather, you know, not comparative to the follicular size that is kind of growing up.
I was a fan of the fixed when I was working in Brussels. Now I hate it. It's completely rigid protocol. It's completely not taking into account what the patient, how the patient is responding. You spend up more medication and you don't allow your ovarian, your ovaries to wake up. So I prefer to use flexible 100% of the cases, especially in poor responders or in PCOS. What I'm doing, I'm mainly focusing on the follicle when I had one above 14. We test also the estradiol, but the strongest determinant should be the follicle. If you see a follicle above 14, try to use it.
Apurva?
Because, 5 minutes. Can we
was a
take
question.
5 minutes?
That's why you froze.
Can we take 5 minutes?
Yeah, we can take. I
Yeah,
still have
okay.
time. We can take 10 minutes. I
10
like
minutes. That's
the Indian audience. I love it. So I'm
okay.
from your country and your people. So I have to.
Awesome. So we have Dr. Sunita Gupta asking, is there any specific protocol that you would want to use for endometriosis?
The studies that have been published up to now did not show that there is a difference if you use agonist or antagonist protocol, and we have published also. So the only studies that have shown is that when you use a depot before a transfer, this can make a difference. So for me, no, I wouldn't prefer one over the other. I don't believe that the long agonist protocol is going to suppress your endometriosis. It has been shown that it doesn't suppress. 20 days of suppression with a 0.1 triptyline or glycerine 0.5 is not going to suppress your endometriosis. So I don't believe this will help your quality of the eggs or anything. And
Even an embryo transfer?
At embryo transfer depends. What I do in endometriosis patients, if it's a minimal endometriosis, stage 3, I don't do anything. If it's stage 3, stage 4, that they need to go surgery, I evaluate the ovarian reserve. I prefer to do one stimulation to get, especially if there is ovarian involvement, to get the eggs, and then possibly I would go for a surgery. The only way to take out your severe endometriosis is a surgery and to clear the inflammation. And if you have good surgeons, not like me that I'm not a good surgeon, you will do very well. So,
and especially, let us say, if someone is on Dynogest, how is your experience with that?
No, for me, I prefer to use a long agon. If I want to suppress endometriosis, it's mainly adenomyosis. Your problem
adenomyosis, yes.
Not endometriosis in this patient. A great percentage they're having adenomyosis, and they will have their implantation failure because of adenomyosis. So if my operator tells me that you have adenomyosis, what I do is 3 months suppression with an agonist, with an analog, and then I transfer. But be very careful. When you stop your analog after 3 months, it's highly likely that your progesterone levels would be crushed before the embryo transfer. So be prepared to use injectables. This is my advice.
I hope that answers your question as well, Dr. Manisha. Dr. Salman has a quick question. Does HMG replace recombinant FSH and recombinant LH? Yes or no?
No, it's different. So for me, I think that they both have a LH activity. So let me explain to you. The LH activity is driven by HG and the LH activity is driven by recombinant LH. Which is the best? There have been studies that showing that HG activity can help on the quality of the eggs. On the other side, there have been studies showing that recombinant LH can help in women that they have specific genetic variation in their gene. There has been a study by Carlo Alvigi in suboptimal responders, women that they don't respond so well. When you add the LH, you can improve your ovarian response. So again, what I'm telling you is that individualization, not one size fits all. Each patient is different.
Honestly, it is so difficult for us because, we start using some protocol and then you come up with another study contradicting that, before we get used to one kind of protocol, you're establishing another. So this is really not fair. But I think we just have 2 more questions. How do you deal with it?
I will reply, Dr. Apurva. It's not that I'm changing. It's that in every treatment or in our lives or in our work, what do we have? We have plan A, plan B, plan C. I want to have multiple plans. And this is the beauty of simulation. If I fail one time, I need to do what I will do then. And if for one of my patients, one protocol is the ideal, it cannot be for everyone. Some patients would respond differently. So for me, what I try to say is that try to have your horizon open and think a different way and also evaluate each patient differently.
Absolutely. I think even with changing time, we as individuals are also changing. Our health parameters are changing. Medications that we have are changing. So obviously, we really can't expect you to give the same results. I think, how are we going to deal with non-synchronized antral follicles?
Non-synchronized antral follicles is something that it's a problem. What we have to do is either increase the dose, start with a higher dose, or yes, use an agonist protocol. This is a population that I'm using agonist protocol. Problem, we have published a recent study this March in which we use contraceptive pills. What we do, we use pills to synchronize the follicular cohort. In an antagonist protocol, if you're not using an agonist, you have two options. One option is to use an oral contraceptive pill, but not more than 15 days, and not with a pill-free interval less than 5 days. And secondly, use estradiol pretreatment, 2 milligrams in the evaluate in the morning, 2 milligrams in the evening, from day 23, 25 for 8-9 days to synchronize your follicular cohort. This has been shown to work well.
And do you use estrogen in the first half of the cycle for 2-3 days in order to, either delay the stimulation for a couple of days or, synchronize the follicles in the beginning?
I use pills. 80% of our patients are using pills. So we synchronize with contraceptive pills for 9 to 10 days. And of course, we avoid weekends with this, which is...
No, that was my question. So on the second day of the stimulated cycle, do you use estrogen as estradiol valerate 2 milligrams for a couple of days in order to schedule your cycle or delay your, trigger date?
Never.
Okay. I think we managed to take most of the questions. One last question I think we have to take is Dufaston use versus injectable progesterone.
Dufaston?
Dydrogesterone, sorry.
Versus injectable.
Yep.
Well, Dufaston in Europe is off-label. Secondly, Dufaston, you cannot measure any levels of progesterone. So what I say to you about the progesterone levels of 10 have zero application when you use Dufaston. You don't know what is happening. Dufaston is not detected in the blood, so forget it. What I was telling you to use injectable, no. The vaginal and the injectable, they are both measured in the blood, so you can measure the levels and you can adjust. For me, Dufaston, I don't have experience. There have come out some studies telling us about promising results. We don't have approval in Europe. It's nice to use an oral pill. Of course, I'm hesitant, especially in artificial cycles, because I don't have the study yet. And I think there is a study being done by the sponsor of Dufaston in Asia, and it will come soon. But I think the jury is still out. Maybe in a couple of years, we'll have more evidence.
We have 3 more minutes, and I will take 1 minute for my question and 1 more minute for Dr. Kundan's question. Aqueous in progesterone versus oil-based.
Is it for you? What would you choose? If it were for you. So,
honestly, I mean, I think Indian women just want pregnancies, and they really do not mind going through that extra trouble. So I tell Dr. Apurva, you have the same chances with one that brings you pain and one that is not. Of course, if the chances are same, which is why we've been using aqueous progesterone all along, and when someone says that no, probably oil-based are much better, so it kind of just starts to. You always feel that pain is good, and unless you kind of have that pain, something comes up, you're not very happy.
So injectable oil-based will give you higher serum levels for sure, and it's okay. But it seems that you need one every 3 days. Aqueous-based you need every day. We have
pregnancy rates is same.
We are showing as we finished the study in which we were submitting now, in which we have seen women with less than 10 nanograms. We supplemented them every day with aqueous every day, 25 milligrams. And we recuperated totally the pregnancy rates. So it works well. But more expensive, daily. Oil-based, every 3 days. The choice is yours. Plan A, plan B.
Kundan, all yours.
Yeah, I think my next question is related to same topic what Dr. Apurva discussed. Now, suppose if we think that we need good progesterone by the day of embryo transfer. So suppose we give a patient, maybe it is a fresh cycle or a frozen cycle, but when we start progesterone, we give vaginal progesterone along with injectable till the day of transfer. Okay, that is intramuscular progesterone till the day of transfer. Because it is very painful, I have achieved my good progesterone levels by the day of transfer, and then I stop my intramuscular progesterone and I continue vaginal progesterone. Is there any evidence that it will affect my pregnancy rate, or probably it's a good strategy to think about it?
That's very beautiful, Kundan. Very, very nice question. So I will explain to you why do we give progesterone? Because we don't have corporal lutein.
Yeah.
So, and we give progesterone that might work in these women because some women appear to absorb differently the vagina.
Yeah.
Problem is that if you stop on the day, when are you planning to stop? On the day of pregnancy test? Or
no, day of transfer, I stop intramuscular and I continue vaginal.
What we have seen is that no, it's not the correct strategy. Why? Because you don't, the problem that we have seen in the studies that published now is not that you have lower implantation, you have higher miscarriage rates.
Yeah.
You don't have corporal lutein, your progesterone is not enough. And there has been also another study by the group of Peter Humaydam with Birgit Alsberg as the first author, published in Frontiers of Endocrinology, or in human reproduction, I'm sorry, in human reproduction, I think, that showing that the progesterone levels, even on the day of beta testing, they are significantly associated with the miscarriage rates. So if you stop too early your intramuscular, while your patients need this, the patient doesn't have any way to produce progesterone. They don't have corporal lutein. So you need to continue for 6 weeks. This is the major problem. So that's why I'm telling you, and I was telling Dr. Pruva también also, that if I continue with injectables for 6 weeks, we're doing harm to these women. It's really hard, and they have. I have seen a patient after these injections, and it's not nice. So I wouldn't like to do it.
Okay.
One question to Dr. Nicholas. You said that you will give once in 3 days progesterone injection. Okay. So in that case, in between, what do you do?
We don't have intramuscular ourselves. So in Barcelona, in Spain, this is based on a study that has been published by Devinet in Fertility Study. I think it's Divine, that's your name. But they randomized patients to 3 groups. One group was a very low dose of vaginal. The second group was vaginal and daily intramuscular, and the other group was vaginal and every 3 days intramuscular.
Okay, so you combine with vaginal. Okay. What's the dose for vaginal progesterone?
It depends on what you use. If you use micronized, it's going to be 600. If you use the pessaries, it's going to be 800. If you use the gel, is 90 twice per day.
Okay, twice
per day. In the frozen embryo transfers, you need twice per day. And this is again by a study that we published. I was a second or third author in RBMO 2014, 15, I can't remember, in which we retrospective study, we have seen that in frozen embryo transfer cycle, when you use twice quinone or the vaginal gel, you have better results compared to one.
Okay. So, Professor, thank you very much for your excellent inputs into our knowledge. Before I say vote of thanks, I request Dr. Ramani Devi to say a few words as a chairperson.
I think it was a wonderful lecture by Prof. Nicholas. I thank you so much. And we should thank Kundan Ingle and the Infertility Committee of FOGSI for having arranged such an excellent program. And the success of the program is shown by the number of viewers who have logged in. I think everybody would have been benefited by this superb talk. And I thank once again Professor Nicholas and the organizers and Intas company, as well as the people who have logged in for this wonderful webinar. Thank you.
Thank you, Dr. Ramani.
1,222 final viewers. That's something fantastic. Yeah.
So on behalf of Infertility Committee, FOGSI and FOGSI itself, we really want to say great thanks to you, Professor Nicholas. I think it is always a wonderful to listen to you with your data, as well as to discuss the question and answer and the doubts in our practice. I think it's really interesting, this question answer session. Maybe it goes sometimes haphazardly, but I think it's very interesting because the way we interact with you, always we loved it. So once again, thank you very much to you. And also to thank Dr. Ramani Devi as well as Dr. Alpesh Gandhi, President FOGSI, for being a chairperson for this session. Thank you, Apurva, for that coordination, excellent coordination. And, it's perfectly, you have dealt with all those questions which we had. And for thanks to Professor Nicholas for giving that extra time to attend those questions. And of course, Mr. Durga Prasad, Intas Pharma, I think with your support for all those logistics, and I request you to say a few words, Mr. Durga Prasad.
Dr. Kundan, I think it was a wonderful session as usual. And Dr. Nicholas, seeing him physically on the stage is a different experience, but listening to him on webinar is again a different experience. So it was wonderful, and the number of audience is probably one of the highest we could see in this webinar series we have done during this lockdown period. So thank you very much. Thank you very much for giving us this opportunity.
So we have to make sure that we will have soon the vaccine, because I'm missing butter chicken.
You have to come on that.
So now,
I know.
through this, you miss the interaction. I think we're much more open people. And
Oh,
so
yeah.
whenever Dr. Nikos is in India, we keep exploring Indian food every time.
I really think we should have another session exclusive for interaction itself, because we have so many more people who have actually asked questions, and I think it would be really amazing if we could have a longer interactive session soon.
Maybe we can organize such kind of session maybe a couple of months later.
Absolutely.
With Professor again. So once again, thanks to all of you for joining in and logging in your busy schedule, as well as, I mean, most important, the viewers. I think the enthusiasm and the eager to know the knowledge, I think it's great achievement and skills you all viewers have. Once again, thank you everybody to all of you. And I here declare that we end the meeting. Thank you.